today we live in a world of technology. We also live in a world where our patients are unforgiving. They expect excellent results from us in all the work we do. They don't expect mistakes from us. And one of the very versatile instruments that has helped us to increase our accuracy rates, prevent mistakes, prevent errors of commission or omission is OCT, Optical Coherence Tomography. Now everybody associates optical coherence tomography with retinal disorders and how it can help in their diagnosis and management. But we need to keep in mind that this is not just for the posterior segment. There is a lot we can do with the OCT for anterior segment problems, a lot we can do in management of our patients with glaucoma. And then, of course, we have what we can do with retinal disorders. Not only that, it's one product which is actually, incidentally, I don't have any financial interest in the product, but there are so many innovations going on that today it's one product which is at the forefront of further developments in many of our ophthalmic diseases. So without further waste of time, we will start off with how OCT can help you in managing anterior segment problems. We have Dr. Hemlata over here. Dr. Hemlata is a senior consultant at Center for Sight in Delhi. She's one of the best cataract surgeons that I have ever come across. If I have to get any member of my family operated, she's the person I would go to. So she has a requisite experience to talk to us about how OCT can change your practice in terms of anterior segment issues. Please go ahead.
A very good morning to all of you. Thank you, Dr. Dinesh sir, for the kind words. So I'll be talking about the applications of anterior segment OCT. And before I proceed, just a brief about the existing AIOCT systems. There are two types of systems. One is dedicated systems that use the wavelength of 13 and 110 nanometers and provide us with deeper and wider scans. And then there are systems converted from the retinal scanners where the wavelength used is 830 nanometers. The resolution is very high, but the scans are shorter in length. The systems that are converted from retinal scanners, we need to use certain adapter lenses for the various scan options. And this is how you visualize the cornea. Almost all the layers are clearly visible on the AIOCT. Now coming on to the clinical applications, the one main application is used in keratoconus. So you can diagnose keratoconus based upon certain criteria in the central pachymetry map. And this is how the keratoconus looks like on AIOCT, and you even have the progression maps if you want to look for the progression. And epithelial mapping is a newer concept which is based upon the observation that the epithelium compensates for the stromal surface irregularities. And we see it as inferior thinning corresponding to the thinnest cornea. It is very useful in detection of the early keratoconus, PMCD, or detection of the early ectasia. Now, even before the epithelium is involved, there is disintegration of the Bowman's membrane, which can be seen as localized relative inferior thinning on the spectral domain OCT. Now, this is a case of acute hydrops, where you can see that the corneal edema has subsided, but you can still see the breaks in the Descemet's membrane with rolled over margins. So, in cases of advanced keratoconus or acute hydrops, you can monitor the response to treatment by doing repeated serial AIOCTs. And this is how the demarcation line post corneal collagen cross-linking looks like on AIOCT. This is a direct clinical indicator of efficacy of CXL. So one can see this line after a month of the therapy. Ultra high resolution OCT can even visualize the intracorneal ring segments very clearly. And you can see if there is any stromal thinning, overlying stromal melt, or early extrusion of the intacs. All these things help us clinically to manage the patients. Now, in a patient where there is a corneal scar, we need to know the depth of the scar to manage it properly. For example, this is a patient who underwent microkeratome assisted LASIK surgery somewhere else. You can see a big scar in the visual axis. So now this patient had a refraction of -2 dispherical with lot of night vision issues, glare, halos, poor quality of vision. So before we proceed for any kind of treatment, we need to know the depth of the scar. So as AIOCT shows, the scar was involving almost the whole extent of the flap, but there was sufficient residual stromal thickness. So we decided first to amputate the flap, and this is how the cornea looks like after a month of the surgery, and the patient had significant improvement in the symptoms, but the post-op refraction was around -2 diaslender. So the patient didn't want any other surgery after that. You can even visualize the LASIK flap through and through with AIOCT, and it can visualize the flap even after years of refractive surgery. So if you want to redo surgery, it's very, very important to do the AIOCT to know the flap thickness. For example, in this patient, the patient has a residual refractive error of -1.75 diopters. The patient underwent LASIK surgery years back, and we didn't know what to do, whether to relift the flap or do the surface ablation. So the AIOCT showed that the residual stromal bed was just 265 microns. So it's not advisable to relift the flap in these cases, so we proceeded with the surface ablation. So here is an interesting case of epithelial ingrowth, which looks like this milky fluid in the periphery. And now in this patient, either we can observe the patient or we can remove the epithelial ingrowth. But if you do AIOCT, the extent of the epithelial ingrowth is much wider, and there was overlying flap melting or thinning. So we decided to remove the epithelial ingrowth. And similarly, this is another patient in which you can see scattered epithelial nests throughout, but post-removal, the cornea was clear. So you can monitor the response to the therapy after by doing AIOCTs. Now it's very important to know the health of the dissect graft for the corneal surgeons. As you can see in this OCT, the graft is very well, nicely attached post-surgery. But there is another patient in which there is a central detachment of the graft. Sometimes on the slit lamp it's not possible to visualize because of the corneal edema if there is graft detachment. So in this particular patient, rebubbling was done, and you can see that post rebubbling, the graft is very well attached with the absorption of the corneal edema. Now, in 14% of the patients, it's not possible to detect the DM detachment on slit lamp examination. They are missed DM detachments. But when you do AIOCT, even in corneal edema, you can very clearly visualize the descending membrane detachment. And in this particular patient, we just injected the air, and within 24 hours, there was resolution of the corneal edema with reattachment of the DM. Now, all these pictures that I had shown earlier was taken on the retinals, the systems converted from the retinal scanners. Now, this one is a dedicated anterior segment OCT system, Anterion. You can visualize almost whole of the anterior segment. It's beautifully shown, a very nicely shown subluxated cataract with a tilt and irregular anterior chamber depth. Again, this picture is on Anterion. This was a patient of uveitis with a membrane formation on the IOL, and that caused posterior synecdoche and pupillary block. So these tools are not only there to improve our diagnostic ability, but also for research and teaching purpose. Again, this is a picture taken on the Anterion, in which the patient had secondary glaucoma post-uveitis, and the inflammatory reaction, which was mixed like AC cells plus pigment. You can visualize that very clearly, and we can monitor the response to the treatment also on AIOCT. Now, the most recent advancement in the cataract surgery is femtolaser assisted cataract surgery. All the systems, they have real-time OCT integrated in it. So we can visualize the whole of the anterior segment, and especially useful in the posterior polar cataract, where you can see the pre-existing PC defect just before doing the laser treatment, and you can just reduce the area of lens fragmentation to leave an epinuclear cushion behind. Now, intraoperative OCT is a newer concept. We are still exploring the applications, But in this patient, it had a PCR, and here you can see that there's a vitreous mount that is prolapsing through the PCR, so you can visualize these things and manage the case in a better way. Another important application is to know the vault size of the ICL. Vault is the distance between the posterior surface of the ICL and anterior surface of the lens. So the normal range of the vault is somewhere around 250 to 750 microns. A very low vault, as seen in this ASOCT image, can lead to the cataract formation. And if the vault is very high, it can lead to the increase in intraocular pressure. Now this patient had inverted ICL. So the surgeon didn't realize when saw the patient on day 1, and we saw, they confirmed that thing on the ASOCT, and we had to take the patient again in OT explant and re-implant the same ICL. So there are a lot of other indications like tear film, meniscus measurements, IOL power calculations, and in infective keratitis also it's very useful. So it's not possible to cover all the indications, applications in one go. So ASOCT, I feel, is a versatile, non-invasive tool for pre- and post-operative assessment of the cornea and refractive surgery patients. And newer technologies such as ultra-high resolution OCT and intraoperative OCT can improve our ability to diagnose and treat corneal disorders in a better way. Thank you. Thank you so much for the patient listening.
Thank you, Himlata. Do we have any questions for Himlata? Otherwise, we'll proceed to the next topic. Okay, so thank you, Himlata. We now proceed to the next topic, which is the role of OCT in glaucoma. And that is something extremely significant, extremely important, and can make a lot of difference to early diagnosis. So we have Dr. Sagarika Patel. She's Major General Sagarika Patel, one of the senior most ophthalmologists from the Army. She's working now in Center for Sight as one of the lead glaucoma specialists in our center.
How and what are the problems and how to interpret OCT and in order to help our glaucoma diagnosis. And I would invite questions, because when you ask questions, then it also helps us to think and give you an answer. So why do we image? Because basically we want to create the foundation for diagnosis. Like you have a clinical examination, similarly we want to image in order to see what my optic nerve is like, what my RNFL is like, and what my macula is like. So therefore, I'll be able to get an objective, quantitative, precise, reproducible. I do it once, I do it again. I'll get the same thing. Of what all? I'm getting 3 structures in one go. I'm looking at the optic nerve, I'm looking at the RNFL, I'm looking at the macula. And macula holds immense promise for us to diagnose early glaucoma. And therefore, we also have software in order by which we can measure change over time, because we know glaucoma is a progressive disease, it's a chronic disease. We want to know, is it progressing or not? Plus, we also are able to find out, statistically determine whether the structural features of ONH as well as of RNFL of a given individual fall within or outside the normal range, and whether there's a statistical significant change has occurred over time. Now, how do I get a good scan? That is the most important tip, and which I would like you all to pay attention to. First of all, choose the right scan protocol. We want something fast, so you just remember the word fast. Fast, minimize motions. Therefore, the artifacts which are caused because of motion, that gets eliminated. Ask the patient to sit comfortably. Adjust your scan position, your scan position, your patient's fixation. Your scan ring adjustment has to be right on the optic nerve. You have to check, very, very important, check for signal strength. If you find, you must check if the patient's eye is dry. Put 1 drop of artificial tears, which you must keep near your OCT machine. Dilate the pupil whenever you want to take the entire scan at one go. Check, moment you get the scan, check if there are any black areas in the scan. Black areas means there is missing data. Check the signal profile analysis, the Tisnet double hump, asymmetry of the discs, and asymmetry of the RNFL thickness quadrant sectors. Check whether it is correlating with your visual function or not. Involve the patient that look this way, so that the patient also helps in improving your scan. Along with that, please do not forget to consider the cost that it involves in this. Don't rely on colors. Ye lal hai to kharab hai, ye green hai to acha hai, etc., etc. Please confirm the normalcy of the data. So do not look for color, just do not look at color. Loss of 5 millimicrons is equivalent to loss of 1 lakh GCCs. You have to do a clinical examination. Without clinical examination and OCT is of no use. Combine analysis of both the GC-IPL as well of the peripapillary RNFL. That is why take a composite scan. It performs better when you're using each individual parameter on its own in early glaucoma. So you take a lot of things, you're able to analyze better. Remember, all tissues affected by glaucoma, they can be evaluated by OCT. That is why in this long length of time with all the imaging devices, OCT has stood the test of time. Now let's have a look at the types of commonly used types of analysis, the printouts that we get. The first one, as we can see, is an OCT, then the by the OptoView. The second one, that's the middle one, is mainly by the Cirrus, which we are all very commonly, we commonly see. And the third one is the Spectralis OCT. Now, Spectralis is an expensive OCT. I don't have the time to carry on with that, but however, let's see how much I can tell you. So first of all, the scanning protocols you must know. You have to have a macular scan in which you have a 6 mm radial line scans are there. Then you have an RNFL scan. There are 1.73 millimeter radius circle scans. And you have an optic nerve head scan. Very, very important. Now, each OCT, it curates a ring scan of its own. That means don't think what a Cirrus is going to, the ring scan will be the same as Spectralis or the same as OptoView, because in a, let's say, RTVU, which we are commonly using, the scan that goes around the optic nerve head, it is 3.45. Cirrus is very close by, it's 3.46. What about Spectralis? That gives you an additional advantage. He says, choose your scan. So you can have a diameter of 3.46, 4.1, 4.9. So that's a great advantage. Let's just talk about the Cirrus OCT, how to interpret it. Your first thing should be going at your demographic data. Is it of the same patient, age, name, ID? Then you must look at the strength. If your signal strength in a Cirrus OCT, as per the manufacturer, if it is 6 and above, or let's say 7, then it's of good quality. Otherwise, if your scan is of bad quality, it's of no use to you. So please look, where is the scan? Where should you look? Look right at the top. I've marked it in red. So I've said image quality is measured by signal strength of 7 and or more. That's of good quality. Now you are in this, you have to look at, I'm with the cursor trying to show you, is my cursor working? No. I wish I had a bit of, it's working? Okay, so now please let's have a look at the topmost thing. In the topmost one, this is the only image you get where a statistical analysis is not taking place. It's the actual image of the patient's optic nerve with the retinal nerve fibers. Now, if you look at what is hot, red is hot. What is hot? Yellow is partially hot. What is not hot is blue, the sky blue. So therefore, we look at the hot colors. Remember, in the top and the bottom of the optic nerve, they are in 2 forms. So in 2 big radiations. Now, if you compare the right eye with the left eye, you find that obviously there's lots more of blue, lots more of sky, lots more of ocean. Therefore, what is there? That means that these nerve fibers have died. This gives you an immense amount of information about how the nerve is like. Now, once you have obtained that data and you have seen that optic nerve head, now the statistical analysis now starts. It's going to compare how much of deviation has occurred. So here you have, this is the deviation map, thickness deviation. Remember, we are looking at thickness. So we find over here what comes in red, look here in the left eye, what comes in red means there's immense amount of deviation. What comes in yellow, that means it is borderline. Once you have finished that, please don't forget to look at the profile map. Now this is the profile map. This profile map is of immense importance because look at this. This is of the right eye where you find that there is one upper one and a slightly lower one. What is that? They are the 2 parts of the upper RNFL thickness. Now you come to the latter part of it, and we find that this is of the inferior part. So now with the one which is of dotted line, that is of the left eye. So that is telling us what is the deviation. Now you're going to compare the two with the normative data, and you what? Now this I will tell you, yes, what is in green is the normal people. What is in yellow is borderline. What is red, of course, is that it's absolutely, it's very highly diseased. So RNFL Tisnet map is very, very important because it is telling you whether my data is falling in the normals or not. Please have a look at the left eye. In the left eye, over here, see, you have seen over here, this is blue. This blue means loss. Look at the, and over here also there is a lot of loss, especially this one. So you find that it is dipped in the red, and of course the lower part, it's almost gone. Don't forget these two maps, extremely important for segmentation purposes. Now let's go on further. You must know what is the normative data of your machine. The Cirrus OCT had 284 healthy individuals, age range, so between 18 and 84 years. Now suppose, for example, you have a 13-year-old girl who has a very large disc and large optic cup, and the person comes to you, then if you try to analyze this data, they are going to compare it with an 18-year-old. So please, this analysis is going to be fallacious. We have different ethnicities also, Caucasians, Asians, African Americans, Hispanics, but unfortunately, 1% of Indians only. Refractive error again is a wide range, -12 to +8. So if you have a highly myopic disc, remember that is not in your normative data. There is also an age-related reduction in the RNFL thickness. Don't forget about it. That is about 0.052 microns per year, and then the rest of it you can have a look at it. So now let's have a look at each segment. So the first thing is, of course, you've got the examination date, and you can see over here that the amount of signal strength is extremely good. It's 10 by 10. Now we have a look at the RNFL thickness, which I've already explained to you. So RNFL thickness map, this gives us the raw RNFL thickness using a color code without comparison with normal data. Always compare the two eyes and you will get information from here. Now look at the RNFL thickness map in a person who is normal, a healthy RNFL. Now gradually the RNFL is decreasing, therefore we're getting more and more of blue. Now we're getting moderate glaucoma, we're finding more and more of blue and loss of the hot colors, and severe glaucoma, you practically have no hot colors at all. Now you're comparing what is the neuroretinal rim thickness, very, very important, and here you find this plot which has been measured. It is showing you where exactly the loss has occurred, and with the normative data. Then the deviation match, which I've already talked to you about, and then again is the RNFL thickness map. And now we're getting going sector-wise. This sector-wise map is very important because it's going to tell you which clock hour your RNFL thickness has actually been lost. This is one thing that should never be forgotten, because these are the tomograms which is telling you whether the data has been correctly taken or not. And this thing also tells us whether the machine has done the segmentation very thoroughly of each and every part of the retinal layer. Now we come down to parameters which are very important to us for glaucoma diagnosis. I told you there were 3 parameters. ONH, this has the greatest diagnostic capability. But what do we see for that? We look at the vertical rim thickness, rim area, vertical cup to disc ratio. Then we look at the GCA. What is GCA? Glaucoma, the ganglion cell analysis. We are looking at the most important area is what? Inferotemporal area, average. Then we come down to super. So first here is inferior, which is very important. Then we come to the superotemporal area, and then the inferior sector ganglion cell thickness. Now the ganglion cell thickness is extremely important. Just have a look at the 2 yellow things. Now they're all yellow all around. Now this has an elliptical measurement annulus centered right on the fovea. Fovea is not taken into consideration. It's the area all around. After that comes the deviation map. How much of deviation has taken place between the normals and the patient here we have done. And of course, then of course is we are looking at the scan, that is the B-scan image. The B-scan image again is extremely important for us. right? Then we come down to, so this is an elliptical annulus, this is the deviation map, this is the ganglion cell thickness, and this is telling us what is the average and minimal ganglion cell layer in a plexiform layer. This is the image, a B-scan image. Now, look at this. This is a loss in the warmer colors. In a typical arcuate glaucomatous pattern, it is known as the nautilus or the temporography sign, which is showing us a discrepancy in the anatomy of the RGCs. Now, this is an optoview scan. I'm typically showing you the ones which are more commonly used, Cirrus, and then comes the optoview. Again, look for the graphics, then look for the signal strength. Signal strength, as per manufacturer, should be 40. So there we were 7 above, and here we are 40. So this is no longer on the top. Now you go to the middle of the sheet. At the middle of the sheet, you'll find that it is 55 and it is 31. Now, here, once you have seen that, after that, please don't forget that we have to now, it is comparing from the very beginning. Here, the hot and the cold colors are not coming in, so that's a disadvantage. But now the immediate analysis goes in. I want you to concentrate definitely on this area. This area is the one that is giving you every parameter. How big is your thing? You have done a clinical examination. You've come to know that this is the size of your optic disc. Please have a look. Is your optic disc that size? It is large. Is it small? Have a look at the optic, the cup. Is the cup small or big as you have determined it? It'll tell you objectively what is the data over there. Now, now look at the signal strength. We had one patient whose signal strength was only, as you can see, 41.8. And we had so many defects in the right eye. Left eye was okay. Now we said, please repeat, signal strength very low. And lo and behold, once we did it, we find everything became absolutely normal. So signal strength is that important. Even the signal strength for the, mind you, signal strength for your RNFL is different, for your ONH, and for your GCC is also different. Here also we find that there's a significant difference once your signal strength improves. Now we come down to the GCC, that is very, very important for us in glaucoma diagnosis. In an optoview, the RNFL plus ganglion cell layer plus inner plexiform layer is the composition of your GCC, unlike the Cirrus. So this is how your analysis takes place. Yeah, and so I am finishing off, wrapping up now. So this is the significance map. These are tilted discs in high myopia and OCT showing you. You must be very careful in macular scan. Remember, OCT is of less useful when it is advanced disease. We have progression analysis in OCT also to help us. It can be an event-based analysis or it can be a trend-based analysis. And this is how the pictures look like. Have a look at it. It'll help you. And you must not forget the red and the green disease. And one thing which has already been talked about by Dr. Hemlata is your anterior segment imaging. And I'd like you to show you something. It was a patient whom we could not see anything. The entire eye, the upper part was absolutely, it was opaque. Now we did the anterior ACE OCT. And you just looked at the video, I came to know what was behind that white colored thing, just like you people also are seeing it. Thank you so much for a kind hearing.
Thank you, Dr. Sagrika. I'm sure you must be having a lot of questions, but we'll finish the lectures first. And please note your questions, and whatever time is left, we will use it for the discussion.
So our next speaker is Dr. Dinesh Talwar sir. He'll be telling us how to read a normal retinal OCT and pathological changes in the OCT in various retinal disorders. Thank you.
So without any further ado, let's go back. Let's go to, we've gone through how you use the OCT for anterior segment and glaucoma. Now what about the retina? Well, the fact is that the OCT is the bedrock on which management of many retinal disorders is now anchored. And not only the diagnosis, but also their management and follow-up. We have different types of OCTs. We have the time domain, which was the first one to come. That's a Stratus machine, which had around 400 scans per second. Then we had now the spectral domain, which is the workhorse. And there you have the OptoView, which goes up to 70,000 scans per second. And the Spectralis, which does 40,000 scans per second. And their axial resolution varies from 3 to 4 micron. And finally, now you have the swept source machines, which can go up to 100,000 scans per second and also have an axial resolution of around 8 microgram. Now, what is an OCT? The OCT is actually a real-time tomogram. It's a cross-section with false colors. So you can do it in black and white also, but either way, either pseudo colors can be used or black and white. It basically images the reflections from within the retinal layers to provide these cross-sectional images. That's because of interference at each level, and the different colors represent different degrees of light scattering from different depths of the retina. Now, if you look at this, this is actually like seeing a histological picture of the retina. Just like you can see the 10 layers of the retina on a histopath, you can see the same things in this, in an OCT. And in fact, for those who don't believe this, look at this. This is the histopath. You have the inner limiting membrane, and then you have the nerve fiber layer, you have the ganglion cell layer, then you have the inner plexiform layer, then you have the inner nuclear layer, the outer plexiform layer, the outer nuclear layer, the external limiting membrane, and then you have the photoreceptors. And you can actually see, what you see over here is the IOS-OS junction. Here is the interdigitation zone. So you are actually seeing a histopathological image, and you can figure out what is going on at every level if your machine is sensitive enough. And this is, of course, a Heidelberg machine. Not only can you do a qualitative analysis, which is very important because you need a morphological study to see how is the form, how is the structure, any difference from normal. You also do a reflectivity study. Is there any area where there's more reflectivity or less reflectivity, any shadowing? And then finally you do a quantitative analysis. How much is the thickness? Is there edema? How much is that edema? Is it becoming better? Is it becoming worse? You can tell all these things. In order to do this, you have various tools with the OCT. You can do a line scan, a raster scan, a radial scan, a mapping, and a volumetric analysis. Now what you see over here, you can see the normal profile. This is the normal depression. So the normal foveal depression. It's like a bow. Now, this is a line scan. Just one single scan is taken. Now, so you know what it looks like. But what if there was a lesion here? You would not be able to know what's happening. So a line scan is not good enough as a routine. You can even have an enhanced line scan. Suppose you want to see a particular area very clearly. So here, only this particular line, it shows you in more detail. But you want to see the entire retina up and down, so you use a cross line scan. So at least up and down you see. But again, you could miss something here, you could miss a lesion on the sides. So what do? We then prefer to do not just the line scans, but also an overview. You see at the en-face image and see what is happening at every level. At the level of the ILM, at the level of the RPE, at the level of the inner limiting membrane. And then you want to do a more detailed scan. You see, each scan will mean more time. So if you just don't want to spend any time, the line scan was fine. But if you want to do as a retinal surgeon, this is not enough for me. So either we first used to do a grid scan, but then we realized even that is not good enough. The grid does give you at every level what is happening. But the best combination we found is a radial scan. So it's centered at the fovea and it goes all around. So I know what's happening in the entire area. And then to make sure I don't miss anything, I do a raster scan, which takes these horizontal lines. They can also be made, you can turn the orientation, make them vertical in all this, but every small distance is covered and you can see what is happening in the entire retina. Finally, you do a retinal mapping so that you shouldn't miss some area in the middle. So you're seeing the whole retina, you map the entire area, you know how much is the thickness in various parts of the retina, whether there's an abnormal part or not. Like this is what you see over here. For example, there's macular edema, and this maps out exactly the area of macular edema, also tells you the areas which are thinner. So both the things come out. You see that even better over here. You see this? This is, white means absolutely the thickest area, red is the next level, the yellow is below that, and blue means thinning actually. Now, just to show you practical utility, see, you cut through various sections, see each, and you know whether a particular lesion is there or not in any particular angle of the retina. The other important thing is what Dr. Sagarika was also telling you, you need to make sure that the scan is of good quality. So first you must identify both the inner and outer bands. You must have a good signal to noise ratio. Check whether there's any area which is getting truncated or which is showing shadowing or there's an abnormal profile. For example, this is not a good scan quality. This again, because of some opacity, you're not getting a good scan quality, but it's good. Supposing, for example, you have an advanced cataract, at least this tells you, no, this is not a normal retina. There is some macular edema. So if it was a diabetic, it tells you, look, it's not just a normal retina, but it's seen hazily. This is an area where, because of a blink, a particular area is not seen. Now, if this was the area where you suspect your lesion, you have to repeat the scan. This is not acceptable. When you see these kind of undulations, and they are at every level, from the inner to the outer, these are again because of movement of the eye. Now, the other important thing is you must make sure you get a foveal cut. Because there's a retinal thickening, you find you actually missed the fovea and you're just taking the retina below. So, go see the relationship to the disc, make sure you go through the entire area and figure out whether you've picked up a foveal scan or not. What about the regions? You have the preretinal region, you have the epiretinal region, you have the intraretinal region, the subretinal region, and then finally the sub-RPE. So what do you see? The preretinal is the area above the ILM. You want to see what is happening in the vitreous there. You can see in this one, there's a PVD. The epiretinal, at the surface what is happening? There may be a membrane there. You want to see what is happening, is it pulling? Intraretinal, whether there's a cyst there, some degeneration there. Subretinal, at the level of the RPE, what is happening? And that subretinal could be sub-neurosensory retina or sub-RPE. Both need to be checked. And what do you see within there? It could be some irregularity, it could be some fragmentation, there could be a rupture, some depression, some thinning or some thickening, just to show you. So the black space is normal. This is a membrane which shows there's a PVD happening over here. You see it even better over here. You see there's a PVD in this area. So above the fovea, you see the fovea here? Above this, there's a PVD. What about the epiretinal area? You could look for a membrane or an adhesion or traction, like you see over here. See, there's a membrane, but there's no effect on the fovea. Here you can see this is vitreoretinal adhesion with a membrane. And here you see this irregular corrugated membrane. So here, again you see adhesion. Here you see traction. You see it's pulled up. And that traction can be broad-based or narrow. Both can be picked up. Here you see a small preretinal neovascular membrane. You have to correlate it clinically, but you can see there's a preretinal neovascular membrane. Intraretinal changes could include edema, hard exudate, scar, atrophic degeneration, like you see here. So here you see a neurosensory detachment. You also see these hard exudates. You see cystoid spaces, and you see some loss of the outer nuclear layer. So all these things can be picked up in the retinal changes. And here you see a large amount of cystoid macular edema. This is the fovea. So you know this is cystoid macular edema, and in this one there's also neurosensory detachment. Here what has happened, you see it's hyper-reflective. That means now it's reflecting a lot of light. This happens from a scar. So this is a scar tissue which is there. Here, if you look at this layer from here to here, you see it's missing. So this is atrophic degeneration. And here what do you have? A loss of layers. All the layers are missing. So you have all the 9 layers of the retina missing. You have a macular hole. On the other hand, here it's cutting through, but the last layer is intact. The RPE photoreceptor is intact, which means this is a lamellar macular hole. And at the subretinal level, you can have subretinal fluid, RPE detachment, choroidal neovascularization, like you see over here. You have a RPE detachment here. You have a depression. This is a foveal, this is a focal choroidal excavation. What you see here is an RPE rip. You see the RPE is cut over here. From here to here, there's no RPE. That's a rupture in the RPE. And here, from here to here, if you look at it, it seems that the ISOS junction is missing. The photoreceptors are absent. There's a thinning happening over there of the photoreceptors. Now, OCT can be used. You can see how many things you can pick up in the OCT. You can use it to characterize your lesions for diagnosis, for treatment, for follow-up, for prognostication. Let's see how. Say, in macular degeneration, what all can you see? Now you see these irregularities. These are drusen. So you can pick up drusen. There's no exudative ARMD. You know, none just needs follow-up. But see here what has happened. This layer is fallen down. So you have a subsidence of the outer plexiform layer in a nuclear layer. It comes down. There is a loss of the external limiting membrane. The ISOS junction is broken over here, and the outer nuclear layer is broken. This is nascent geographic atrophy. This is dry degeneration, doesn't need treatment. But what do you see here? There's subretinal fluid, there's an RPE detachment, and you have a type 1 CNV. This is an RPE detachment with subretinal fluid. Now, when the same lesion is above the RPE, like you see over here, there's some scarring here, and there's a lesion here. Some granularity here. This is a type 2 CNVM above the RPE. And the third one is type 3 CNVM, which is in the substance. You see it, this yellow. A very small thing, a yellow lesion over here in the substance, going downwards, more clearly seen here. Coming into these, so there's a small lesion in the retina, goes down, causes a RPE detachment there. That's a type 3 CNVM. What we call a RAP lesion. Now, you've done this is a patient with the CNVM. Now, this is post-PDT, those eras. We did the treatment with PDT and you see the whole thing's gone. Now, it's gone, but there you see what happens, this line becomes red. That means there's a hypertrophy of the RP there. CNVM resolved, but some scarring is there. What about this? You have a patient, RPE detachment is there, subretinal fluid is there. How do you monitor? You see the next time, you see the fluid is gone. You follow up, and then when there's a recurrence, what do you see? Intraretinal cysts have come. So you diagnosed, you followed up, you picked up the recurrence. All the things you can do on the OCT. What about this? You had an RPE detachment. You can see this RPE detachment, also seen on the fluorescein angiography. And then over time, this patient rips. You see over here? Now, till here you can see the RPE, here there's no RPE, and fluid has developed over here. This is an RPE rip. Still needs to be treated. You can't stop this treatment, but now you know the visual prognosis is not as great. What about this? Here you see fovea is thinned out. But you see this round cartwheel thing, it looks like a cyst. It's not a cyst. This is cartwheel-like, it is thickened walls. This is what we call an outer retinal tubulation. Don't start treating these lesions. They don't need any treatment. It's a sign of severe degenerative change. On the other hand, you can also have central serous choroidoretinopathy. Here you have a neurosensory detachment, but what do you see? The RPE is normal, except for the small area of an RPE detachment, which can happen even in CSR, but the RPE is absolutely normal looking. So you know this is not age-related macular degeneration. This is CSR. This is a chronic CSR. Again, nothing's happening to the RPE. RPE is normal, but there's a little thickening at the level of the photoreceptors. You know, this is called a brush border sign, accumulation of waste products in the photoreceptor outer segments on the outer surface of the retina. Now, one way to confirm, are you dealing with CSR, is to do the choroidal thickening, check of the choroidal thickness. You can see over here, this is done by what we call enhanced depth imaging. And what do you see over here? The choroid is very thickened. This again has fluid, but now again RP is normal. And what do you see? This is raised in one side in the horizontal scan, but in the vertical scan it's straight. This is a condition called dome-shaped maculopathy, occurs in very high myopes, not a treatable condition. So you need to recognize it because you otherwise will keep on treating it. This is a patient who has a lot of exudation, and this excessive exudation or excessive hemorrhage in a patient who's around 50, 60 years old is a sign of polypoidal choroidal vasculopathy. And what do you see? You see these kind of irregular RPEDs, peaked RPEDs, and then if you look at this RPED, shallow RPED, within that you find another layer. It's called the double layer sign. So this is a sign that there's a branching vascular network under this. These are all signs of a polypoidal choroidal vasculopathy. So any sharply peaked PED, a double layer sign as you see over here, a thick choroid with dilated vessels and some fluid, these are all signs that help you to diagnose polypoidal choroidal vasculopathy. Just repeating this. You see this here? This is like M kind of sign. This is again a sign of polypoidal choroidal vasculopathy. But you must also differentiate what we call adult Whitley-form degeneration. Here this lesion looks like a CNVM. On angiography, you'll see actually the leak, the hyperfluorescence doesn't increase too much. That should give you the first doubt. If you look at the OCT, it looks like that there is some amorphous material there. But if you do a autofluorescence, you find it's hyperfluorescent. So you know you're dealing with. So combination of this autofluorescence with this kind of picture on OCT, you're sure you're dealing with adult Whitley-form degeneration, which does not need treatment. And the other condition is juxtafoveal telangiectasia. Juxtafoveal, again, here it looks like an occult CNV. Late phase, there is a lot of leakage in the macula. There is increased hyperfluorescence, and if you look at the OCT, it shows these changes, but these are cystic changes. These are degenerative cystic changes, and this kind of picture is again characteristic of juxtafoveal telangiectasia. Now, as far as what do you see in the retina, macula per se, you see this membrane here. This is a blunting of the foveal contour and epiretinal membrane. What do you see here? A macular hole treated and became normal. You can also tell whether your macular hole has a good prognosis or not by doing what we call the hole form factor. You see the ratio of these two layers to this layer. If it is 0.9 or more, you know your hole will close with surgery. If it's less than 0.5, the chances of closure go down. You do a cataract surgery. Patient not improving. Just do an OCT. You see there's CME. Treat this patient with NSAIDs and low topical steroids. This is what you'll get. Normal. So, for you to ensure good prognosis for your patient, good outcomes, this is an important thing. Another condition is arterial ischemia or venous ischemia. You see here, there's a CRO occurring over here. Now let's see what would it look like. This was actually a patient who had a detachment surgery and developed a CRO after that. Very scary situation. You can see the inner layers become opacified. This is characteristic of a inner retinal ischemia, a central retinal artery occlusion. And then with time, this will go away and the retina will become thinned out. This is the less scary thing, a CRVO, still scary but not as scary. You can see these multiple hemorrhages and you look carefully, you see this macular edema, neurosensory detachment, and then you treat this patient, becomes all right. You can follow up and stays all right for some time, again develops a reaction, the edema, again needs treatment and improves again. So you can use the OCT for your follow-up after pharmacotherapy. You can see what's happening, you know when to retreat, you know whether to just do a follow-up in these patients. A branch retinal occlusion, not only will you get this edema, but this edema is now localized, either to superior or the inferior quadrant. So it doesn't cross the midline. So if you do a vertical scan and you find that the edema is on one side only, you know you are dealing with a PRVO. So you can actually make a diagnosis on OCT and then you can treat the patient accordingly. Ladies and gentlemen, in diabetes, there are a lot of patients whom you need to see, and both for diagnosis, treatment, follow-up, prognostication, you need that. There are various lesions called drill, subretinal fluid, intraretinal cysts. All these we'll just go through. Now, the commonest thing is intraretinal cystic spaces. They can be small, large, or even giant. Or very large cystic spaces, if they are left to stay for a long time, are associated with a poorer prognosis. So you don't want to do that. Now, important thing is to treat them and see the response, and you can pick that up. You see here, this was a patient who was being treated with anti-VEGF agent, was not responding, finally was given an Ozurdex, and you see the response started coming within a month. Subfoveal neurosensory detachment occurs in 15 to 30%, may be related to either hypoalbuminemia or because of patient having hypertension. They affect the vision much less, but they can. What you see here is a small neurosensory detachment. What you see here are the cystic changes. So you can recognize the edema. Patients being treated, edema became less, developed this neurosensory detachment, was still treated, everything became all right. So you know how to stop treatment, when to stop treatment in your patients. An important condition which you need to recognize, because this can sometimes cause poorer vision in your patients, is called disorganized retinal inner layers or drill. See, if you see this area here, all the layers are seen. Here, these layers seem to be clumped into an amorphous material. This lack of ability to segment the boundaries of the ganglion cell layer, plexiform layer, inner nuclear layer, these are all a sign of drill. This is how you diagnose drill. Now, this is in the central 1 millimeter, and if we know that if more than 50% of this area gets involved, it's a significant poor prognostic factor. And this is a very reliable factor for prognosticating a patient with DME. Supposing you have a patient, doesn't have too much edema, and has this drill, now you know this patient may not improve as much. Okay? But don't talk about drill in the presence of a lot of macular edema. Because if there's a lot of macular edema, it can push the retinal layers. And that can give you a false appearance of drill. Now, just to show you, here there was fluid. It looked like this area had drill, but the fluid went away and the layers became okay. So don't comment on drill while the fluid is there. The other thing is here, lot of big cyst, but no drill. Vision was good. So this is another important factor to keep in mind. The basic parameters which are predictive of good visual outcome include subretinal fluid. It's better than having intraretinal cysts, absence of hyperreflective spots, integrity of the ISOS junction. You may have any amount of cysts, but if the ISOS layer is intact, chances are your patient will have good vision, and after treatment will have a better visual outcome. I'll just show you what hyperreflective spots look like. They basically represent activated microglia. It's an inflammatory change, and more hyperreflective spots are associated with early recurrence after a steroid implant. So these show all the things, the subretinal fluid, intraretinal fluid, and what you see here, these are hyperreflective spots. What you see here, even more clearly seen, these are hyperreflective spots. Now, just to show you, this patient, you can see the ISOS junction is intact. Despite these cysts, good prognosis. This patient, the ISOS junction is gone, poor prognosis. Finally, remember, in our country, we want to decrease the number of injections. You want to know whether I can laser my patient. A retina map can tell you, see this? I know the fovea is spared. The macular edema is away from the fovea. This patient, with a combination of anti-VEGF agents and focal macular laser, will do very well. So this is what you can get if you do the thickness map in these patients. One more tip for you. When you see these kind of processes, these are called bridging retinal processes. These are basically Mueller cells, so they are allowing this area to give the nutrition from the lower to the upper, from the outer to the inner retina. It's a good prognostic sign. If you have these, patients are likely to do well. So ladies and gentlemen, I've taken a lot of time, but basically OCT is the workhorse for retinal disorders. Diagnosis, management, follow-up. It's non-invasive, sensitive, and provides a detailed insight into the pathoanatomic changes that occur in the retinal microarchitecture and has revolutionized the management of retinal disorders. Thank you very much, ladies and gentlemen. And without any further waste of time, I'm going to ask Dr. Venkatesh Ramesh to come and tell you about the last word in OCT, which is OCT angio, and that is the cutting edge, and he's going to tell you more about it. And after that, if there's time, we will discuss.
Everyone, it's very strange for an IC to be a houseful IC, and this is something which is very rare to be seen these days. Now let us look at this fundus photograph, and we all know that this is a case of diabetic retinopathy. Now we want to stage this diabetic retinopathy because your staging is very important, because if it's a proliferative disease, you want to end up treating this patient with a panretinal photocoagulation. But if it's a case of a severe non-proliferative disease where you don't have these abnormal new vessels which are developing, you tend to observe these patients. But the way to identify what stage of the disease is, you want to do a fluorescein angiography, and that is where most of the people will do a fluorescein angiography, identify those abnormal areas of new vessels, and then see that, okay, now this is a stage of proliferative disease which we have, and therefore the patient needs to be treated. But to run a fluorescein angiography in a clinical practice, especially with general ophthalmologists and medical retina specialists, what you require is a trained technician to acquire those images. It's an invasive technique which is dye-based, and it has got a high risk of allergic reactions, and therefore you end up having an anesthetist or an emergency backup which is required in these cases. While a general ophthalmologist requires imaging which is non-invasive in nature, which is non-dye based, the images have to be easy to acquire, they should be safe with not any exposure to any allergic reactions, they are less dependent on the technicians and the anesthetists, and it also provides an on-first information of the retinal and the choroidal vasculature with segmentation, and also provides a simultaneous OCT scan. And this is what a one-stop solution is what you require, where you have the OCT-B scan and you have the on-first imaging of the OCT, where there is segmentation which is happening at the different layers. So when you look at the OCT angiography of this patient, this is the superficial capillary plexus which is there on the left side, and what you can see is a front or a front of new vessels which are growing, which is suggestive of a foveal neovascularization, and the capillary dropout areas which are seen, and the deep capillary slab which is actually showing you where these new vessels are sprouting out and they are coming from the new vessels. So with this basic information, I'll be talking about OCT angiography, and I'll be actually replacing or substituting Dr. Naresh Yadav, who's currently who was not able to come for this meeting. OCT angiography, it basically provides an in vivo 3D vascular information by using the flow of the red blood cells which are in the blood vessels and enabling the visualization and the quantification of the functional vascular network which are there within the microcirculatory vascular beds, and it is non-invasive in nature and it does not require a dye to be injected. So OCT angiography is a wonderful new age tool which tells you a lot about the vascular information and the segmentation through the changes in the red blood cell motion. Now let's talk about the clinical applications of OCT angiography, and let me start with the most common disease, that is diabetic retinopathy. We know that diabetic retinopathy is a disease of the deep capillary plexus, and when you see most of the OCT angiography machines, they give you 4 images which are on-fast images. The extreme left being the superficial capillary plexus, then you have the deep capillary plexus, the outer retinal slab and the choriocapillary slab which is there on the extreme right. Now when you know that the deep capillary plexus is the one which is affected in the diabetic retinopathy, you can see in the second slab or the second image, you can see a lot of hyperreflective dots which are present, or comma-shaped structures which are suggestive that these are microaneurysms which are present, and you can also see there areas of capillary dropouts or capillary rarefaction which is happening, and therefore you can diagnose this case that yes, there is some amount of subclinical diabetic retinopathy which is present in this particular patient. Let me show you another case, which is a 65-year-old patient which being diagnosed with proliferative diabetic retinopathy and treated with diabetic macular edema with anti-VEGF injection. Now you can see here on the OCT-B scan that the macular edema is resolved, but the visual acuity hasn't improved much at all. And when you do the OCT angiography in this patient, you will see a lot of areas of capillary dropouts in the superficial and the deep capillary slabs, which is clearly suggestive that there is an extensive macular ischemia which is developed, and that is the reason why the visual acuity of this patient has not improved despite having a dry macula in this case. Now let's look at another reason why OCT angiography would be useful in a non-invasive way is to identify those abnormal new vessels which are sprouting out towards the vitreous side. So overall, if you look at the OCT angiography in diabetic retinopathy, it is to identify the subclinical stages of DR. It is to identify macular ischemia and account for the poor visual acuity improvement, and also to identify new vessels at the disc and elsewhere. Now let's look at the second common disease which comes to our practice, and this is called as the BRVO, or the branch retinal vein occlusion. And you can see on the clinical photograph, you can see the sclerosed vessels which are present in the supratemporal quadrant, and also those vessels which are extending towards the macula. Now when you look at the OCT of this patient, you can see that the retinal architecture is distorted in the supratemporal region, which clearly suggests that there is extensive capillary dropouts and capillary rarefaction which is noted in the superficial and the deep capillary slabs, which is clearly suggestive that there is an ischemic variety or an extensive capillary non-perfusion which is developing in these cases. So retinal vein occlusions, whether it's CRVO or BRVO, the OCT angiography is not useful in acute cases because you have extensive hemorrhages in those cases, and in presence of macular edema, the OCT angiography may not be very useful because of the segmentation problems which you will encounter with. What it is useful is in identifying chronic cases where you want to identify or pick up macular ischemia and also retinal neovascularization secondary to a vein occlusion. Now let's talk about another common disease which you encounter in clinical practice, which is macular telangiectasia. And in macular telangiectasias, you basically want to identify the different stages of MACTEL and detect whether you have a secondary neovascularization which is developing or not. So let's look at what happens in the superficial slab in cases of macular telangiectasia. You can see there is a distortion of the capillary architecture on the temporal side to start with. And when you go to the deeper slabs, you can see these abnormal telangiectic vessels which are very well identified on the OCT angiography. Now pigment plaques, which is a stage of macular telangiectasia which is seen in the stage 4 of the disease, is a non-vascular kind of an entity. So you cannot see those pigment plaques on the OCT angiography images, but you can see them in the en-face OCT images. Now the right angle dipping, you can see this dilated right angled vessel which is dipping inside the retina. That is a very characteristic feature of a macular telangiectasia stage 3, and you will eventually see that this is in the outer retinal slab. You can see this entire front of secondary neovascularization or subretinal neovascularization which is seen in the case of macular telangiectasia. So various stages of macular telangiectasia, right from the earlier stage, which is the development of the telangiectic vessels, to the late stages where there is a development of a secondary neovascularization, can be identified with OCT angiography. Now, age-related macular degeneration, that's something very, very important, very commonly seen in day-to-day practice. And what you need to understand, you have the two forms of age-related macular degeneration, the dry and the wet forms. And the dry form, the advanced stages of the dry form is what is called as the geographic atrophy. And then you have the advanced stages of the wet disease where you tend to have the macular neovascularization. Now let's look at a case of geographic atrophy. You can see this entire area of RP atrophy which is seen on the clinical image, but you can see some amount of vascularization which is seen in the choriocapillary slab. The reason why you see those vascularization is because of the RPE loss. And when there is a loss of a tissue, the underlying vasculature, which is the choroidal vasculature, becomes more obvious, and therefore you have what is an artifact, or there is an unmasking because of the loss of the RP, and therefore there is unmasking of the choroidal vessels. Now let's look at the more important ones, which is the type 1 CNVM, which is located underneath the RP. You can see in the choriocapillary slab there is a front of neovascularization which is developing. And then when you do the type 2 neovascularization, you can see that this neovascularization has entered into the subretinal space, and you can see that in the outer retinal slab. And finally, you have the type 3 neovascularization, or which is called as the intraretinal neovascularization, which is seen in the deep capillary plexus. If you look very carefully, this is a very small front of new vessels, which is seen in the deep capillary plexus slab of the OCT angiography. Now, OCT angiography is not without artifacts. It's very difficult to interpret an OCT angiography And if you look at this review article, the OCT angiography artifacts ranges from around 72 to 100%, and the most common being motion artifacts, projection artifacts, segmentation artifacts, the masking and the unmasking artifacts, and the flow-related artifacts. Now, these artifacts are primarily can be because of the device itself, the patient, disease itself, the software-related problems, the operator operator or the technician related problems and the abnormal disease related problems. So I just want to summarize this entire talk with saying that OCT angiography definitely provides a good or useful information of the microvascular network by detecting the changes in the OCT signals due to the moving of the red blood cells within the vascular channels without using an intravenous dye injection. But this is possible if the media clarity is good, if the eye fixation is good, if there are no opacities in the vitreous, if the retinal thickness is uniform and the segmentation is accurate, if there is no intra or subretinal fluids, and if there are no structural changes like heme, hard exudates or plaques, and there is always a corresponding B scan to correlate with the OCT angiography signals. Thank you very much.
Thank you, Venkatesh. That was a nice and sweet lecture, and I think conveyed all the important points. Are there any questions from anybody? Yeah, please go ahead. Can we give a mic, please?
Good morning, sir. So in case of tilted disc, how to assess the RNFL in these patients?
Madam, in a patient with a tilted disc, how good is an RNFL?
No, it isn't. It isn't because we don't have tilted discs normative data.
Okay.
So that's why it becomes very difficult. In fact, tilted discs is one thing that for glaucoma people, whether it is whether you're doing a field or you're doing an OCT, becomes very difficult. So there are other methods by means of, let's say, diurnal variation, continuous follow-up, create a baseline for this patient and see whether there's progression or not. That's the way to go about it. Otherwise, there is a lot of information coming up on tilted discs. You'll find it probably in one of our books that is coming out. Please read it. I think it will help you a lot.
I think the important thing is OCT is not a standalone investigation. All investigations must be used in combination with your clinical evaluation. So if you miss the diagnosis, then you'll make a wrong interpretation. So you're absolutely right. So first you make your diagnosis correctly, and once you made your diagnosis that there is a tilted disc, now you have to be careful about how you interpret the findings. Dr. Patel, I would like to ask you, you have a patient who's got OCT changes on RNFL. Now the patient gets a fields done, the fields are normal. What do we do about such a patient?
Yeah, so we often get these type of patients where the OCT is showing changes. Now in literature we find that OCT may show changes 4 years before a visual field show changes. Now unfortunately the data is still not robust enough for us to start treating. Otherwise everyone will start treating OCTs. Now we are not treating the OCT, we are treating the patient. So all you need to do is call the patient for an earlier follow-up. If you're calling the patient, let's say for example after 6 months, please call the patient after 3 months. Follow it up. Is the OCT increasing or not? And are there any risk factors or not? If the patient has risk factors plus OCT changes, then even if the field does not show changes, I will treat.
So, and on the reverse stays also that if the patient already has complete loss of the retinal nerve fiber layer, you don't need to do the OCT anymore. You can just do the fields on the retina.
So I have definitely said this, unfortunately, one of my latter slides.
No, I mean,
so we had to.
just reiterate
This is such an important point. If you have got advanced glaucoma, you've got practically no neuroretinal rim, then in that case, your OCT is of no use to you. Neither use to the patient, neither use to you. So don't do it. Go with the fields, with the 10-2.
Then how to start treatment in patients with tilted disc? What are the factors
Ma'am,
on which we decide?
try to first of all do the entire clinical examination. Take a very good history. If you find that there are risk factors, there's sibling history of glaucoma in the family and all that sort of thing. Look at the CCT, look at the pressure changes, do a good diurnal variation. Call the patient again maybe after 3 months and check. Because we know glaucoma is a very slowly progressive disease. There are very few fast progressors. Therefore, once you do that, you might be able to catch the patient. And when you see there's a change, which is a decided change, and change means you've done it at least once or twice the investigation, showing the same reproducible defects, in that case, treat.
So if you have a tilted disc and you've done an OCT, you've got some changes, and you follow up on a 3-monthly basis, and after some time you find a progression, you could use that as an indication.
That's exactly what I'm saying, sir.
So that could be one point. And of course, if you will be doing the fields, you're not treating the patient with only the OCT changes anyway. If you get any field changes, the combination is enough for you to treat. One more point I'd like to make before
Thank you, sir. Thank you, ma'am.
OCT diagnose that there is a choroidal neovascularization. But it does not help you to decide when to stop treatment because the vessels never completely disappear. Some degree of vascularization may persist. They may become mature. They are still there, but they are mature. You don't keep on treating those mature vessels. So please note, you use the OCT angio to decide about does the patient need treatment. But you don't decide when to stop treatment. During follow-up, you can actually see a new recurrence. If there's a recurrence, you can actually pick up the change in the configuration again, and you can use that as an early modality for retreatment. So you use it for initial treatment, you can use it for picking up a recurrence, but you don't use it to decide when to stop treatment. So this is important to note. And with these words, I'm going to now conclude so that we can finish on time. We started a little late, but we're finishing on time. And I must thank you all for being here. We all appreciate the time you've taken to be with us here today. And I think we enjoyed presenting. Thank you very much.